Good evening, everyone. I am known to like to start on time, so we're going to do that. Thank you so much, everyone, for coming to yet another amazing meeting of the San Antonio Free Market Medical Association. We are probably the best chapter in the nation. Wouldn't you agree? Folks that from Houston do not agree, that I understand. But you came. Thank you so much, Dr. Dixon and her team from Houston. We have Frontier Direct Care who came from Harlingen. Thank you so much. And also Dr. Peter from Rio Grande Valley. So thank you so much also for finding your way here. And because we are so visible, I get a call about every other week because we have a website that is very visible that we made. And people talk to me, and most of them, I think, are realizing that there's a trend here and that people are catching on. A lot of is happening, but what I hear also is that when I listen between the lines, there's starting to be attention from people and companies who really come for the profit. And that's not what this is about. And one thing that I know for sure is that everyone who is here tonight is really here because they want to make a difference. And that is probably the greatest gift you'll get tonight, is that you can meet people who are really in it to provide better, more affordable access to high-quality healthcare. And I'm always pleased when I meet people who are interested, who know that there can be a better way, but they had no idea that there's actually an association that promotes that movement. So that is why I believe that continuing to have high-quality meetings with high-quality conversations where we can educate ourselves and our communities is going to be forever important. The hardest people to get in the room are the employers because it's hard for them to understand. And yet they are responsible for most of the access to healthcare in the nation. So I urge you that take this information and bring it to your employer friends, and also invite them to future meetings. That would be very, very good. We're going to also at the end take a nice group photo, so please make sure when we wrap up the Q&A you don't leave too fast, so we can take that photo and give our booth another look that will help you as well really understand what people have to offer here. Let's see, what do I do next? Okay, so this event, as you can tell, is in a nice ambiente, and it's not possible to do that without sponsors. So I want to really take a moment to give the sponsors some spotlight. And I will start very selfishly with my own company today. One thing that we have really focused on recently is teach individuals, some self-employed individuals, and also companies how to have a very strong presence on LinkedIn to build a brand. And we have a free challenge coming up that starts on Monday. If you go to our table and scan that QR code with a picture of me and Sinead, then you can participate in that. It takes about half an hour per day, every day next week. So that's for Shanks. Now, moving on to the other co-founder, DirectMed Clinic, represented of course by Dr. Roger Murchigamba and his team. We have a great video that I think really covers a lot of the basics of what the movement is about, so I'm going to show that now.
Medical Association is an organization that's founded out of Oklahoma, and the whole purpose of that is to help fight the high cost of healthcare through price transparency. Our approach to creating the free healthcare market in San Antonio is to bring together the parties involved, namely the payers of healthcare, those are employers, and then the providers of healthcare, the doctors, the hospitals, the facilities, and then also to invite a few brokers into the mix who get the idea and who want to serve the needs of their employer clients. The Free Market Medical Association has a part of their website called Shop Health, which lists providers and facilities where folks can go and shop health and see what the cost is. Part of it is to give providers and facilities some support across the country to venture out and create this model or this approach to affordable health care. Then another part of it is also to raise the awareness of people and employers. And like I said, employers are the ones who pay for the majority of healthcare throughout the country. And I get kind of excited and passionate about showing employers who want to take care of their people an affordable way to do it. I mean, we've had employers come to us and use our direct primary care model because they were buying insurance for their employees and they weren't using it. And then when they found out why they weren't using it, well, because the deductible was so high or this or that. So they changed their approach to it. And so this direct approach has tons of value. The FMMA is a vehicle to do that, to raise the awareness of this direct approach. It's kind of sad that traditionally folks go to the doctor or the hospital and they don't know what it's going to cost. How did we get to that point, right? There's ways to access these prices. You know, they're on ShopHealth, they're on Lasso, all of the prices are posted on our website, and all of the members, the provider members of the FMMA, have prices posted on their websites. Now, I went to medical school to become a doctor, okay? I learned how to take care of people. And there's the magic right there. It's when a doctor and a patient get in a room, that's where it all starts. And it can get so confusing and frustrating with the other parties involved if they don't need to be. I mean, everybody knows we need insurance, it has its place. But it's really satisfying and gratifying to me as a medical doctor to be able to provide the care that people need. In this day and age, the way that healthcare has been a little bit shaken up by the pandemic, that there are a lot of smart people looking at alternative ways to access healthcare. I have no doubt that what we're doing at the MMA and in direct primary care is going to continue to grow, because people are always going to find what they need. That's the American way.
All right, next we have a video from... We have a video from Family Hospital Systems, who I believe were not able to be here tonight, but
all business owners are interested in providing access to health care. They've always been interested in offering benefits to their employees because they want to take care of their people. Employers love the flexibility of having a group healthcare membership where they can simply add and remove employees as needed. There is no waiting periods, and benefits become immediately activated. If you're wanting something that's simple, direct, and easy to understand, and really takes you out of the decision-making seat, I really encourage you to look at K-Tree Care. Small business owners.
All right. Okay, so next I will ask Harlan Pickett, who represents Eagle Care Health Solutions, to come up to the lectern and tell us a little bit what they have in store for you.
Without talking too much about Eagle Care, if you want to learn more about that, talk to us afterwards. I want to talk about why we're actually here tonight. If you all saw that study that came out here a couple of weeks ago, it pointed out that 70% of Americans believe that the healthcare system has failed them. If you're a clinician in this room, you should be appalled by that. You should also be appalled by our audio room that we're having next week on the 20th that has almost 200 people that want to attend because the name of it is Why Does Healthcare Suck? Whenever I announced that, Dr. Roger almost came and threw the camera at me because he knows for a fact that in his practice, healthcare doesn't suck. And I would venture to guess that those of you that are clinicians here, at your practices, healthcare doesn't suck. But 70% of Americans say it does. What's wrong? What's wrong with this picture? Well, those of us that are in this room know what's wrong. It's not the health care, it's the access, the processes you have to go through to get that health care, the administration of that health care, and who's doing it. That's the problem. It's not a free market. We are on the cusp of making huge inroads and making a difference. We should all be appalled, not just clinicians, but every single one of us should be appalled that 70% of Americans believe that the healthcare system has failed them. We live in the greatest country in the world, and our healthcare system sucks. There's no excuse for it, but we're going to make a difference. And I applaud every single one of y'all for being here tonight to do that.
Another faithful supporter of our organization is Alison Dr. So Alison, if you'd come up and tell us how many awesome solutions you have for
I'm not really sure how I'm supposed to follow that.
So I know a lot of DPC docs. I've been very fortunate that way. And one of the questions that I get asked a lot is how to talk to employers and how to show the value of what DPC is. And you know, businesses are operated for profit, so you do have to show value to an employer. So I'm going to give you a couple tips on how to do that tonight, and I'll be happy to answer any questions afterward. So first, you need to talk to the CEO or the CFO. CFOs are typically the most trusted leader in an organization, even more trusted than the CEO. And CEOs, they're executive functions. So they're looking for talent management, legacy, how to grow their organization. So I think you can have a good conversation with the CEO about what direct primary care can do for their organization, not just from a fiscal perspective, but from a human perspective as well. And I think quite often we forget that we're treating humans, or employers forget that people that go to doctors are humans, and we just kind of get shoved through this system. So the more conversation you can have about not shoving people through a system that most people think is failing them, the better off you are. Access to care is now, I believe, 26 days. So it takes people 26 days from the time they need a physician until they get to an appointment. Now, if I'm going for my annual physical, that might be okay. If I've broken my arm, if I think I'm having a heart attack, if I'm having a diabetic issue, probably not so good, right? Employers are not unaware of this. They just don't know what to do about it. So tell them what you can do about it. Then you need to prove your data. So you need to have a good system that will allow you to show that you're not just an expense, that you are an investment in the workforce. There are a couple of software platforms that can help you do that. Some of them will even allow you to do a retrospective look back. So you can literally say, give me your claims data. All employers are entitled to their claims data now, by the way. Get the claims data, run it through a system, and come back and say, okay, this is what you spent in this category, this is what you spent in this category, and this is what you spent in this category. Had you had a DPC program implemented, or even an on-site clinic, this is what you would not have spent. Preventing overspend is a big deal to a CFO. So talk that way. Talk about how to treat a medical plan budget as a capital expense and not as an operating expense. And honestly, it's always going to be an operating expense, but if it's treated like a capital expense, then it becomes more valuable. It becomes more valuable to the employee, and it becomes more valuable to the employer. And continue the conversation. Don't give up after one or two times. Employers sometimes take a little bit of time until they steer the ship in a little bit of a different direction. So don't give up. And I'll stick around if you have any questions afterwards.
Thank you, Edison. It is now my pleasure to bring Dr. Roger Mochigamba up for a short address, co-founder of the chapter.
Thank you. So I'm so happy to see everybody here. I'm thankful for our guests for coming kind of a long way. I'm so excited of what we're doing here in San Antonio, where we've come from. We're trying to build a free healthcare market here in San Antonio, and we're making good progress with that. And that's been our vision from the very beginning. So thank you all for coming, and if you feel what we're doing, if you like what we're doing, please help us grow this. Bring somebody with you next time, okay? Now, I want to give you an example of what I'm very excited about. We have pretty much the whole healthcare spectrum beginning to be represented here. If you are a primary care doctor here, please stand up. Awesome. Thank you. So if you're a secondary care doctor, like a specialist, please stand up. There you go. Thank you. And we saw the video of Family Hospital System. That represents a tertiary care facility. So primary care, secondary care, tertiary care, we have it here in San Antonio. Now, secondary care, you guys didn't stand up.
Okay.
Surgery center, okay? So now, are there any employers here? Stand, okay, very good. So, thank you. So now employers can look around the room and see the different components, direct care components that they can use for providing health care that's cost effective and efficient, okay? And now for the larger employers, we can't make it work without the expertise of the right kind of brokers. So if you're a broker, please stand up. Awesome, thank you. So that's what I'm really excited about. So I'm also super excited to have Zak here. I'm gonna sit down and we'll let Shankar introduce our guest.
Thank you, Dr. Roger. morning.
Yes. Okay, I forgot one thing. I wanted to share a little bit more about the wonderful stuff that we do in this direct care model. So I asked Dr. Salas if they could share a quick success story from their practice of something that illustrates the beautiful direct care model. Could you stand up and take just a second for that?
Yep.
Can everybody hear me? Okay? Can y'all hear me?
Yes.
All right, hi everybody. I'm Dr. Musa, Salas, a family medicine, lifestyle medicine specialist here in town. Direct primary care since 2018, 2019. King's fan since then, King's user since then. And I mean, direct care is obviously our passion. That's what we do. My wife joined me back in 2021, so we now practice together. Dr. Martinez asked me, can you share any successes about direct primary care? I mean, there are countless, I'm sure, as other clinicians here to tell you, but one thing that caught my attention just a little while ago, Allison said, what was the time to care, to access care, 26 days, I think is what she said. I can't tell you the number of times that we've actually seen new patients same day. I mean, it happened literally today. Just actually two. She saw one, I saw one. One of those actually came to me over the holidays. Supposedly just some heartburn reflux type of issues going on, but actually it turned out she was in DKA at the time. So diabetic ketoacidosis, very dangerous. She had no idea she was a diabetic. But luckily, because we were able to get low cost labs and things like that, got everything taken care of. Did end up admitting to the hospital. I don't admit, but I was able to follow along the entire time she was there. I called her, I texted with her, I spoke to her care team, to my nurses, spoke to their nurses. I mean, I was on top of her care the whole time. What was that costing her? Just what she had paid for that 1 month of care, right? Which is honestly not very much compared to what a single office visit anywhere, even an ER visit will cost you. But as soon as she was discharged in a stable state, I was able to stay in close communication with her as well the entire time. And fortunately, because of that, and because we practice a lifestyle medicine curriculum, if you would, with our patients, we were able to actually get her on very little insulin, maybe a couple, 1 or 2 oral medications, and with her determination to actually get this new diagnosis under control. I mean, I can't tell you the number of visits I had with her over the course of about four months. She lost weight, about 15, 20 pounds, and she's a very happy, controlled, low-risk diabetic at this point. Again, in the traditional practice, there's unfortunately a lot of times there's not a whole lot of follow-up after a hospital discharge, or you have no idea what happened, you can't communicate with anybody, you just don't have the time a lot of times, so you're seeing 20, sometimes 30, 40 patients in a day. But because of the model that we practice here, again, it allows for that. So I always tell my patients, it doesn't matter if I see you every day. I don't mind seeing you every single day. If that's what you need, right? I'm here for you. So this patient, fortunately, again, very grateful, very stable with what she's doing, and we're rocking and rolling. She's a happy person.
Thank you, Dr. Ross. Dr. Musa, they're specialists, would you share a quick success story?
Hi everyone, my name is Musa, and I am a neurologist and epileptologist along with my husband, the other Dr. Musa. We opened Kingdom Healing Institute, which specializes in epilepsy, neurology, chronic pain, and addiction medicine. And we officially opened May 26th. We had our grand opening, which is a huge success. And I'll say that just within a few weeks of opening, we've already had a few success stories. And specifically with neurology, there's a huge problem of access to see a neurologist. Typically, patients have to wait, if not 26 days, probably 3 to 6 months to get in to see a neurologist, let alone an epilepsy specialist. And we have been getting a lot of patients who've been finding us organically, through Google. And one patient called, actually it was the mother of a patient, and she called just very, very distraught because her 2-year-old son has been having a lot of convulsive seizures and falling and hitting his head. She did not know what to do. She had been taking him to multiple neurologists over, I'll say, probably a 10-year span. And lately, she just couldn't get in to see a neurologist. She was so desperate, she was thinking of traveling either to Austin or Houston. But again, probably not for several months. So when she did find our website, she was really beside herself. She thought maybe it wasn't real. I said, yes, I can see your son the next day. And, I saw him. I was able to put him on appropriate medication, including a rescue medication, benzodiazepine, so that way we can control the seizures quickly. I adjusted several other medications. I was able to call and follow up the next day to see how he's doing, and much better situation. We've had some headache patients come in as well, and they've gotten very, very quick access to care. We're able to even get them infusions in the office to abort the migraines. They don't have to go to the ER. So it's been great. Yeah.
Everything she said.
Thank you so much. How valuable is that?
Thank you. That's awesome. So we get to the part now where we have our amazing guest speaker, Zak Holdsworth, present to you very soon. Zak and we have a lot in common. We're both entrepreneurs, although he is a little bit further along than I am. But I really appreciate that, having role models in this industry. And the other aspect is that Zak is an immigrant to this beautiful nation and makes his American dream come true by helping other people, leveraging technology to bring transparency and also to really help this movement to become stronger and better, foster collaboration. And with that, Zak, if you would come up and tell us how you achieve that every day.
Thanks for having me, everyone. It's a real honor to be here. I was at the FMMA conference in, where was it, Roger? Dr. Roger? What was the last FMMA? Kansas City, yeah, and Andrea walked up to me and said, we'd love to have you come and present, and we finally made it happen. So it's a real honor to be here, and I think it's quite amazing what this community has done and put together. I was actually asked the question, before I jump into this talk, I was asked the question, what are the things that you can do to improve what you're doing here? And my answer was, I'm not actually sure. I think you're doing such a great job. And especially compared to a lot of the other chapters, it seems like you're actually really excelling. The one kind of point I made, though, was that with these types of movements, I tend to think that what's important is not big leaps, but small gradual improvements, small gradual change over time. Because what that is, 1% better every week, or if you can just continue to improve a little bit every month, then you'll end up actually compounding the impact. And so I actually think that it's really great to see this movement, so keep it up. Maybe just a little bit of background on me. Our vision at HINT is to redesign the healthcare system to enable easy access to high quality and affordable care. And we, as mentioned, I come from New Zealand. I actually grew up on a farm in the middle of nowhere. I had a different type of healthcare experience when I was growing up. And at some point I might share some of those stories, but when me and my co-founder were trying to figure out what is it we can do to help realize this vision, and it really came down to supporting, from our perspective, supporting the growth and success of the DPC movement. And so that's the kind of the foundational level. We believe that DPC is a big part of the answer to transforming US healthcare, and that's why we built the company and why everything we do is sort of dedicated to supporting this movement. And we now have the honor of powering thousands of DPCs. We actually recently ticked over 1 million members on the HIND platform across a few thousand DPC doctors, and we've got lots of great clients and testimonials. But we're really proud of what we do at HIND. So that's a little bit about me. And I was asked today to talk about how technology is powering free market, and sort of ruminating on this topic a little bit. And what I found myself, I think this is an interesting conversation, and there's a bunch we could talk about here. I mean, we could talk about the work that we're doing with our technology and how it's helping make it easier to launch a successful DPC. Most of the innovative free market kind of solutions in the market are leveraging technology. So technology is a critical part of this movement. But from my perspective, it's not really the core underlying kind of important conversation. From my perspective, actually, I was sort of ruminating on this, and I actually think it's really more about how innovation is powering free market. And what I mean by that is that if you sort of tend to think, if we use DPC as an example, the innovation is not really technology, right? The innovation is not even necessarily the medical training that's happening, right? The innovation is the underlying business model that unlocks the ability for these doctors to do the types of things we just heard here, which is really, profound, right? These profound innovations. But I was sort of thinking about this as well, and if you kind of think about the US healthcare system, we all know this is probably preaching to the converted, but relative to other sort of modern economies or advanced economies, it really is underperforming, right? The healthcare spending is off the charts, and performance is pretty abysmal relative to other modern economies. And so, and actually, my favorite analogy actually here is for those of you who've heard me speak, you're probably sick of this analogy, but we're wasting basically NASA's budget since inception every year in the US healthcare system, right? So that's including Apollo mission, the man on the moon, the Mars mission, the rover mission, every mission, right? The space station. That's the waste every year in the US healthcare system. So it's kind of quite hard it's sort of almost uncomprehendable how broken the system is. And from my perspective, actually, the interesting topic actually is not how innovation is powering free market, right? From my perspective, actually, the interesting conversation here is actually how free market is powering innovation in the US healthcare system. And what I mean by that is that the status quo, status quo infrastructure, right? We're not going to be able to iterate our way out of this problem, right? We need fundamental underlying innovations. And so I was kind of thinking about this and trying to figure out how can I kind of talk about this. And if we think about the US healthcare system, right, this is the Warren Buffett, I think, was famously quoted as saying it's the insurance of the fee-for-service infrastructure is really the tape room of American economic competitiveness. The majority of payments in the US healthcare system run through insurance fee-for-service infrastructure. And that includes actually a lot of the shift to value-based care, right? That's an abstraction layer that sits on top of the fee-for-service chassis. It's adding more complexity and ultimately, at the end of the day, has, from my perspective, been somewhat of a failed project. And so I was trying to figure out how can we kind of talk through this. And who here has kind of studied or heard of the Innovators Dilemma? It was a kind of a famous Harvard professor, Clayton Christensen. Who's heard of this framework? Okay, cool. So this is one of my favorite kind of frameworks for thinking about innovation and disruptive innovation. And the way to think about this is, on the left you've got kind of performance, on the bottom you've got time. And the way to think, typically the way disruptive innovations disrupt markets is, and actually I'll use an analogy here. Back in the day, there was an analog radio, right? And then eventually the transistor radio became the standard. And so the way that happened is that you have the performance demanded by the top end of the market, right? So the very high quality audio, very really kind of sophisticated product that was, everyone was using to listen to the radio, right? And the innovations, what was happening is these innovations were incrementally improving. They were getting better and better and better every year, but they weren't really step change innovations. But then what happened is the transistor radio came along. Now the transistor radio was pretty crappy, if we're going to be honest. If you listen to the stories, it was really poor sound quality, right? But it had the advantage of being cheaper and portable. So if you're a kid and you want to listen to the radio at the beach, you can afford to do that. It's not going to be great sound, but it's going to be better than no sound. And so what happened is the transistor radio started down here with this much lower performance, right, relative to the incumbent status quo. But then over time, slowly but surely, the quality got better until the point where actually it was better quality than the analog radio, but it was still cheaper and portable. And at that point, it's game over. So that's actually not the innovator's dilemma. The dilemma is, if you're this guy, right, if you're the analog radio, your ability to innovate is cut because you're not, to the extent where you do innovate and bring this product to market, what you actually do is you destroy your own business. You undercut your own business and essentially destroy what you've built. So as a CEO, you've got infrastructure, you've got branding, you've got massive supply chain, you've got the gross margins on your product, you've got all of these things that make it very difficult to innovate. So if you were to innovate, you actually smash your underlying business and you get fired if you're the CEO. That is the dilemma. Now the reason I bring this up and I use this kind of framework is I think it's a very good analogy for what's happening and why I think these free market models that are coming online and why they are going to ultimately beat the status quo infrastructure in the long-term horizon. So as I mentioned, we're a DPC company, so the free market innovation that I'm going to use here as an example is direct primary care, but I think you can apply this to many other free market models that are out there. And if we look at the direct primary care sort of framework through the lens of the direct primary care framework, what you're going to notice here is direct primary care when it started a decade or so ago, it was mostly focused on the consumer, the least demanding customer was the consumer, right? Listen, I'm willing to just pay, $75 a month out of pocket because I want access to my doctor, right? And I really just want to be able to see my doctor. I don't really care about, necessarily like total cost of care and having it deeply integrated with plan design. I just want access to my doctor. And so what you see is the DPC movement starting to slowly but surely build and grow over time. And then up at the top of this, the most demanding customers, right, these that have been served by the status quo infrastructure, which is incrementally improving, but actually, I would argue it's actually going backwards. So it's actually sort of innovator's dilemma squared, maybe. But at the upper end of that, the employer-focused DPC, deeply integrated with plan design and surrounded by other free market products where all of the entities in that ecosystem are collaborating, and there's essentially unlimited supply, so there's no shortage of folks that can provide the coverage needed for all of the patients in the population. Okay, that's what the most demanding customers are going to need in order to implement these types of disruptive innovations at scale. But what's interesting about this is, again, the sustaining innovators, right, their incentive is to not do this because it will destroy their underlying business models. The same as the analog radio. If the analog radio guys did the transistor radio and brought that to mainstream, it would have destroyed their underlying business. And that's one of the reasons why I believe that these free market forces are going to continue to drive change. And when you sort of compare this, when you look at DPC, right? If we look over the last, say, decade in healthcare, there's been about a 50% increase in premiums in insurance. We did some research a few years ago, and this is the HIMSS Direct Primary Trends report. This is based on thousands of clinics. We did independent research. This is a our data analytics team spent probably a few hundred hours developing this report. But I just wanted to pull some of the interesting data points out of this. So if you were to look at the traditional status quo healthcare system growing at 50% over the last decade, what we see with DPC is the cost actually dropped a little bit, right? Because it's free market and the DPCs were reacting to the market. And so this is kind of one manifestation of how this innovation is actually different, right? Another thing that I found really interesting when you looked at some of this data, during COVID, we all heard these stories where essentially what happened is many of the insurance fee-for-service primary care clinics essentially went bankrupt, right, or nearly went bankrupt, and actually it was near impossible to get access. And that's actually on top of the 22-day and the average wait time, where actually even that went away. While DPCs, if you look at the growth rate of those DPCs, they continue to just grow. And many of the stories we hear from our clients is actually COVID was actually they actually thrived during COVID because they were providing a really great experience for their members, and they were actually the trusted advisor to their members, and they were going to be the last thing folks let go of during hard times. So that's another interesting thing. We also see the growth rate is consistently growing. So this shows essentially, growth in DPC physicians as a percentage of per capita, something like that. Anyway, it's going up, right? Also, number of people in the per capita number of people that have a DPC. So these charts are all sort of going up and to the right. And interestingly, the percentage of DPC by who's paying, is it the individual member or the employer? We're starting to see an increase in employers. So shifting from that least demanding customer to the most demanding customer, we're slowly starting to see that transition happen, which I think is really interesting. But then the question is, okay, there's this disruptive innovation, it's really amazing. We heard these incredible case studies, I loved it. The question is, why is it not happening faster, right? We're sort of in the middle here somewhere, right? We're kind of coming up this chart here. And this brings me to another framework. I like all these different business school frameworks, which is Amara's law. And typically, humans struggle to understand exponents or exponential or things that have orders of magnitude more scale. And typically, we have linear minds, right? We sort of go from here to here and kill that animal over there for dinner and then go back over there, right? We don't, if you're a hunter or gatherer, right? You sort of, the human mind is a fairly linear sort of computer, I guess. And we tend to think linearly, but actually, so what tends to happen is folks will actually overestimate the impact that an innovation will have in the short term, but they'll underestimate the impact that innovation will have in the long term. And so why this is interesting is I believe that, and actually a really good real-time example of this is actually AI, right? So everyone's been kind of saying AI is kind of not, unless you're in the AI field, you probably didn't really spend a lot of time thinking about AI recently. But over the last year or so, or really over the last few quarters, that has completely changed, right? We've been underestimating the impact these things can have, and actually now we're sitting over here, and the impact is going up sort of through the stratosphere. And so my view is that with DPC, the reason we've seen this more linear growth is because we're pre this inflection. But I believe it's coming, and we're going to be blown away by the impacts that these free market models will have on fundamentally transforming US healthcare. So it kind of takes me on to this analogy, which I was sort of messing around with, which, who remembers back in the day the saying, no one ever got fired for buying IBM? Is it just the older guys? Us older guys? Yeah, okay, fair enough. Well, this used to be a thing that people would say. And the idea is that it's the sort of de facto solution, it's a sure choice. What was interesting though about this is that over time, what happened is actually the narrative shifted to, well, you're not going to get fired, but you're not going to get promoted either, right? So I was sort of looking at these. I was looking for these images, and this one came up, which I thought was quite funny. Which is I won't read it out because we've been recorded. But IBM messaged shareholders and customers and employees, and so ultimately over time you kind of get to the point where, I don't know, maybe you actually would get fired. I don't know, maybe I'd actually put one of my employees on a PIP or performance improvement plan if they installed an IBM mainframe to run our servers, right? Like that's probably not a good idea. And so as I was messing around, I sort of was like, okay, well, I actually was asked ChatGPT, hey, what are some other good memes about IBM? I thought this one was quite funny. Is it just me that finds memes funny? Yeah, okay, cool. Well, so anyway, the analogy though, I think that's interesting is that, this is another one it made for me. Nobody ever got fired for buying me and changed my mind. So it's another pretty funny one. But the thing that I think is interesting is, the perspective is, I actually think you can apply this to, let's say, the big 4 health plans, right? A decade ago, you're not going to get fired for installing a big 4 health plan, right? Now, I just heard who was it that told me about the 41% increase? Yeah, Harlan, great example. He just had a health plan renew their coverage with a 41% increase. I don't know. I'd probably maybe consider firing the person that renewed that, right? Like that's probably like not a good deal. So I think this is my view is we're getting very close to the point where folks are going to be forced to start looking at other innovative models, especially advisors. That we're saying that the advisors that are here, right? You're the guys that are actually going to be thriving. Because all your mates who are still just pushing the same old stuff, right? Over time, my perspective is that the CFOs, the CEOs, the folks that are actually putting the money down to pay for these plans, even just consumers paying out of pocket, my view is that we're going to get to the point where it's untenable to not do something innovative, and people will get fired, right? So that's my sort of warning to folks is you want to get on the bandwagon. And I love this meme. This was another one ChatGPT made for me. I thought it was pretty funny. Sorry. Yeah. Anyway, so back to the sort of the thesis here around the status quo kind of fee-for-service healthcare infrastructure. The way the problem with this, right, is it lacks price transparency, right? These are just obvious kind of axioms, right, of the world, right? If you have a system that has no price transparency, has perverse incentives, right, or lack of, really perverse incentives or lack of good quality incentives. But my perspective is that the problem is not lack of good incentives, the problem is the perverse incentives that exist, right? That's the bigger problem. And the crazy high administrative overhead, right? These are untenable, right, and just don't make any sense, right? And when you look at direct primary care, it's price transparent, right? You know how much you're going to pay. It has nice natural incentive alignment. Okay, we just heard some great case studies, but you don't need to give the doctor a bonus to provide good care when they're getting paid to do so in a recurring way, in a way where all the incentives are aligned, right? So. And you don't have to have all the high administrative overheads, right? It's one of the reasons we exist. One of the things we can do to just make it easier and easier and easier to operate this model. Now, the thing that's interesting though is I actually think these are generally kind of concepts that I think apply to many of the free market options that are out there. And we tend to sort of label this as direct care at Hint. And the vision we have at Hint is that we tend to think that the way to transform the healthcare system is to build a kind of an ecosystem of transparently priced products and solutions that are grounded in a foundation of affordable primary care. And direct primary care in our mind is the way to do that. And this is kind of the vision that we're sort of driving towards at Hint. It's not that insurance is not important, right? But those common predictable care is moved out from under the insurance umbrella. And the very expensive, unpredictable, high impact incidences those are the things you leave in the insurance arena, But it just makes more sense. It's the way pretty much every other insurance industry works. And so that's kind of the vision that we have at Hint, and I'm really excited to be part of this community and part of helping drive towards a healthcare system that is really great for everyone and is affordable and importantly that not only for patients but also the providers and the doctors and the nurses that are actually delivering care. And so that's kind of it for today. Happy to take any questions, but it's been really fun thinking about some of this and sharing this perspective. So thank you very much.
Oh, you want to take your questions now or do the...
Yeah, Roger, what's next? Do you want to...
Yeah, we do a little Q&A.
Yeah, okay. Yeah.
So Zach, Hint Health, y'all are a network of direct primary care physicians?
So, yeah, so I'd say our business is, we've got a few things we do at Hint. The kind of main thing that folks know us for is our software. So we're basically, these doctors are doing membership-based care, so we're a membership management system. If they're working with employers, our employer infrastructure helps them with eligibility and billing the employer. We also power DPC networks, so a lot of the networks run on Hint. And we recently actually acquired an EMR designed specifically for DPC, so that with the goal of kind of consolidating more of the technology and making it really easy for new doctors to get started. But I think the thing you're alluding to is we also recently launched a new offering called Hint Connect, which is really designed to kind of help scale DPC by bringing essentially bringing employers or innovative health plans, making it much easier for them to interact with our ecosystem of customers at scale for a single contract instead of needing 200 contracts. So Hint Connect is the sort of newer offering. But then we also have an education arm as well. So we do Hint Summit, which is our annual conference. We have Accelerator, we've got our Thrive programs, is just designed to help DPCs to launch and scale and grow. And I think that's it. There might be some other stuff too, but that's the main stuff.
From a DPC's perspective, we use the software, probably the other docs in here too. It helps us tremendously to keep track of our members, and we can sort them and manage them, and it's just a wonderful technology tool. And with the innovation that they're leading with, we're able to use it to scale as well, and that's a beautiful thing because in order for this to continue to grow, as Zach was showing, the blue line going to the red line, it's going to have to scale. Right? I want to ask a quick question.
Yeah, fire away.
What does Hint mean? Where did that name come from?
Yeah, so in the early days when we were trying to figure out what we were going to do, we were actually looking at a bunch of different things. But one of the things we knew we wanted to do is something that was sort of like intelligent or kind of new or exciting, and that would actually potentially change the system. And so Hint actually stands for health intelligence. So a friend of mine started a company called Mint, which stood for money intelligence. And so we kind of a little bit copied that. And then the logo is about sort of the interconnectedness between the doctor and the patient, right, sort of coming together. So if you look at our actual branded logo, that sort of comes together as one at the tip of the heart. So that's kind of what the inspiration was for that.
Okay, thank you. So you can see, I knew the answer to that. I knew what Hint, health intelligence meant. So you can see that Zach is leading the industry in that, health intelligence. So thank you for doing that. Zach, another question that I was thinking, do you think that the blue line is going to connect to the red line? Are they going to cross?
So you're talking, we get through the memes, everyone can have a chuckle at those. You're talking about this one or this one? Yeah, so I think, one thing you've got to do with these frameworks is not take them too seriously. But I think that ultimately my view is on a long enough time horizon that the blue line will completely take over. Right? From my perspective, it is inevitable on a long enough time horizon. Right? The question is, what is that time horizon? And again, the way I tend to think about this is that, you know, being on the inside, it feels kind of slow actually, right? The growth, right? In my head, when I started this company, I thought DPC would be, let's say, an order of magnitude further along than it is, right? It's still growing well. We saw the growth charts. But in my head, I was thinking it would sort of be an exponential growth curve. And I think that the sort of back to this is that, you know, we're just seeing the beginning phases, I think. And my view is we'll start to see exponential growth over the coming years, or, you know, and this is the part that's hard to predict. It's like, I don't know, is it 1 year, is it 5? I don't know. It's probably not 10 though, right? That doesn't feel right to me.
Are there some things in the economy that you think might accelerate the growth?
Yeah, I mean, I just think generally, my view is that just the pain of cost compounding at 12% a year, like, if you keep compounding at 12% a year, you will, in a lot, you know, not that far off, bankrupt, it will just be like all of the GDP, right? Like, it will literally bankrupt the most powerful nation to have ever existed, which actually comes back to one of the underlying missions of why I'm doing what I'm doing, is I think if the US empire fails, the world fails. If the world fails, this will be the first catastrophic failure at global scale of an empire falling, which will take the whole empire down. So actually, my personal mission is actually save the world. Because I think if you bankrupt the US economy, then bad stuff happens, right? So short version is, I just think the pain of compounding cost increases will force people to, I mean, that example of 40%, like, what are you going to do? You're going to look at something else, and if that something else is less expensive and better, let's give that a shot. Right?
Thank you. So I'll share a little personal vision of mine is, you know, I look around and I see struggling in healthcare, access here and there, high cost, and I might share this vision with other docs in here. I want to do my part. I can help that patient. I can help that patient. I can help that company. I can help that company. And as I do my part, and Dr. Salas, Dr. Musa, the other docs in here do their part, we come together and we all make a huge difference. So it's not a top-down solution, it's a bottom-up solution, right?
Yeah.
But so that's why I love getting together here today and having you come and give us this high-level vision. But in reality, all of us getting together we can make a difference in San Antonio. So that's why I keep asking, you know, stand up if you're this or that and bring people. So thank you.
Yeah, I mean, you know, just on that point, I think, you know, change happens through sort of compounding growth, right? Just small incremental improvements that compound over time. If you always stay on a positive vector, eventually you take over, right? It's just the math, it's just the way it works, right? So I agree with you, just keep pushing. Might be tough, it might take a while, but eventually we will transform the US healthcare system.
We are. So we're going to start in San Antonio with our sphere of influence, and we've got the technology behind us to back up. And so I'll stop, and we'll start taking some questions out of that.
I'm going to lead into a question, Zach. That is, I know Dr. Roger loves you, a good friend of mine and future business partner in about 3 weeks. Henry Johnson at ARC.
Oh yeah, awesome.
Loves you guys. So I noticed up on one of your memes you had Stephen Crowder up there.
Which meme was that?
Louder Crowder. What a great way to get the word out. This guy.
Which one is that?
He's part of your sovereign nation, right? He's a Canadian.
This guy?
No, that guy.
This guy, yeah. Yeah, I love this guy.
He's awesome. Get on his show, his podcast, and talk about exponential growth. It's very popular.
For sure. I mean, and just credit to, where credit's due. I typed in, give me a meme about IBM into ChatGPT, and this is this is one of the things that came up. So,
awesome. Good stuff.
Okay, questions? So far, do we have another mic?
But I can walk.
I tend to look at things at macro to micro.
Yep.
So I just want to ask you a quick question, although I have about 40 questions for you.
You sure? Go for it.
So one quick one for the sake of the audience. Who do you bring to the table to brainstorm and innovate? Because there's a lot of different aspects you're facing that most people don't know. So who would you bring to the table?
Yeah, I mean, this is the thing I get in trouble with at work, because I'll often, call a random junior employee and want to chat with them about what they're working on, and get in trouble because their boss is like, you really freaked out this employee, they thought they were going to get fired. But I think maybe the point I'm making is that I tend to think verbally, and I tend to think sort of through interacting with people and through discussion, and sort of, a lot of the concepts I was exploring today, for example, were through kind of conversations, or this is really I see this as a conversation. So maybe short version is I tend to, I've got in my senior leadership team, I spend a lot of time brainstorming with them, and I've got a kind of a safe word now with them, as I say, I'm riffing. And what that means is that I'm not telling them that I want to buy an EMR. I'm talking about I'm brainstorming what we could do if we were to do that. So when I use my safe word that I'm riffing, sort of people in my circle tend to sort of let me run, and will often meet me as well with other ideas, and you can kind of cascade ideas to the point where you end up with something that actually makes sense. So short version is lots of conversations with as many people as possible is how I do it. I don't know if that answers your question. There's no single person, I guess. To me, it's like interacting with many people, which is actually one of the reasons I love talking to our customers. Yeah.
How are your EHR systems able to communicate with clinicians, physicians, hospital systems, labs, and come up with kind of a care plan for the members in whatever group?
Yeah, I mean, our EMR product is super early. It's the intention of our EMR product, what we call it Hint All-in-One. I'd say the intention actually really is not necessarily right now about large, at-scale, DPCs with very sophisticated needs. It's really more about what can we bring a product to market that makes it very easy and inexpensive, simple, easy to use for a small startup DPC that's just getting started. So a lot of the super fancy stuff that you might come to expect from an EMR, the stuff that's not annoying, right? There is some good stuff in the products out there. A lot of that doesn't necessarily exist in our product. We're trying to bring a lot of different things together. So it's got communication, scheduling, basic charting, medical history. You can order labs. You can do kind of all the things you'd need, and it's integrated with our billing infrastructure. But it's not, I would say, a very sophisticated product yet.
Thank you.
Yeah. And the intention is really just how can we accelerate the growth of the movement by making it much easier for someone to get started without having to purchase a bunch of different things. Yes?
All right, so something that y'all been working on, and you mentioned a little bit about Hint Connect. Could you share a little bit with this group some of the success stories maybe that you've found and ways to integrate different DPCs, especially cares into a direct contract, and specifically in maybe Texas, what are some ways that we can work together to strengthen that?
Yeah, totally. I'd say Hint Connect is pretty early, right? We started with Hint Connect. I tend to, when we do new stuff, you tend to be like nail it before you scale it, right? And I'd say we're now only just moving into the scaling phase. Well, maybe inching into it. The first year or so was really about legal infrastructure, contracting, getting licensed in each state that we're operating in. We're now, licensed in 35 states, which is like a nightmare to get that done. Getting the early doctors, like Dr. Roger is one of the first to join Hint Connect. We've got, the Hint Connect footprint is now, it's actually now bigger, close to, I think, like, crossed One Medical or something in terms of scale, right? So, we're just getting it in. And then really this year has been our first in earnest go-to-market year. And one thing I will say is Hint Connect today doesn't directly integrate specialty care, right? It's purely, the contracts we have with the doctors are purely DPC. So there's no kind of natively integrated specialty or option. But I think, and then really this year is really the first go-to-market. So there's a couple of ways we're going to market. One way is through our existing kind of doctors on the platform. If they have an employer contract and they've got 500 employees in their local region, but they've got another 50 in 3 different regions, instead of going out and building out that network themselves, they can just use Hint Connect to expand their footprint. So that's actually a use case that's actually working really well for our clients because it's really easy and it's fast and it saves them time and time and money, and it ultimately ends up helping them close more business because they're able to say to the employer, hey, we actually now have greater coverage. And the other go-to-market is where, in instances where there's an employer that, let's say, has a much broader dispersed geographic footprint, then they can actually direct contract with Hint Connect and we'll connect them into all of the doctors. We haven't yet formally kind of done what I consider very sophisticated plan design around like a high performance narrow network of price transparent cash rates for specialists downstream. Like that, we haven't taken on that yet. It's mostly focused on how do we scale and make the DPC piece more accessible at scale. But you guys are pretty good at that. Maybe you should answer that question. The frontier DPC folks, you guys are actually weapons at that type of thing. So, yeah.
Hi, really enjoyed the talk.
Thank you.
You said something that really piqued my interest. You said that you thought the DPC movement would be further along. And after speaking with patients that do direct specialty care, each individual I speak with, each patient I speak with, it seems so simple, the concept that you have a membership or you actually have time and access to your doctor, and that if you can deflect the useless monthly fees, that doesn't mean you have access to care, you just have the privilege of paying that deductible. Patients love this concept. So in your opinion, why hasn't this grown as quickly? Because I think when you speak to individuals, it makes perfect sense. But when you try to speak to larger groups or employers, I think there's a disconnect, but I don't understand why.
Yeah, I mean, part of it I think is just momentum, right? Like, it's a big system, it's complex. Educating everyone on what may seem obvious once you've kind of thought about it, it's like, there's 300 million people to educate, right? And it's going to take a while. But I'd say I actually think I think that pretty much everyone has a form of Stockholm syndrome with the current healthcare system, right? Like the patients, there's like, hey, insurance is the way it is, right? That's what they've been trained. The employers, they have a form of Stockholm syndrome. It's like the big four, right? No one got fired for buying one of the big four, right? The doctors, right? This is the way it's always been. This is the way I'm trained. This is expectations set in medical school. It's just like everyone has been basically jerked, and it's just going to take a while to, at a psychological level, I think, for people to realize actually maybe there is a better way. And in fact, you actually see that. The sort of anecdotal stories of patients or even if I'm just explaining what I do to someone new, to begin with, I'll be like, hang on, can you just say that again? Right? Like, I don't understand. Or like, what is there not to understand? It's simple. You pay a monthly fee and you get unlimited access, and it's awesome. Right? And you sort of repeat it a few times, and then you go, wow, that's actually a really good idea. But it's sort of, it's not just like immediately, it doesn't click immediately for people. It takes a few repetitions. And so I think repetition is really important, and especially with employers, because of this reason. But we're going to get there. It's going to happen.
Well, I think your slide says it.
That slide?
It says that HR people aren't fired for offering Blue Cross or United. They're
not yet.
Interested in new ideas that are going to get them in trouble.
Yeah, that's right. Yeah, for sure. That's right.
What are the barriers to, and how do you see overcoming those barriers to the incorporation of us tier 2 docs, the sort of the next level? How do you see us moving that way?
Yeah. For a start, I think there's some. Let me just go in a different direction on this. So, the reason we started with primary care is because, well, partly there was a movement there, right? We were like, wow, this is pretty cool, why don't we support this movement? But when you sort of peel the layers back on that decision, the reason is because not all, but a lot of the referral pathways come from primary care, right? And so one of the patterns we observed was that these DPC doctors, and this is 8 years ago when there was like 80 DPC doctors, right, or whatever, like it was, maybe it was slightly more than that, but it was pretty early. But one of the patterns we saw was these DPC doctors would often go out and build their own kind of local ad hoc network, where they have the mate that has an imaging thing and he's got a cash rate for imaging, and they'll figure out cash rates for labs, and that they would have they would sort of have a friend that was a specialist, and they would kind of ad hoc negotiate this stuff on behalf of the patients where it didn't make sense for them to use their insurance because they're on a $5,000 deductible, and the copay is like $50 or whatever, and then they're going to pay $250, so it's like $275, and it's like, hey, or you can just pay $75 cash right now and they get the same thing. So that's actually a little real example. So maybe the sort of short version of the answer here is, my view is that the way that we need to integrate direct specialty care to scale it, I think that just like DPCs just going out and putting their shingle at, just basically starting a business and going to market independent, that's a great start. But the way I tend to think that we scale it is figure out how do we make it so that all of these DPC doctors have ways of sort of connecting with local direct care specialists in a way that's not necessarily ad hoc. And the green imaging folks here as well. There's great case studies there of how this can work in imaging as well. So short version is I do think it needs to be integrated with the DPC. And exactly how we do that, we or the community or whatever at scale, I don't know, but I don't see a world where it's not that, right? Like that's, from my perspective, the gating step in bringing all of the special along at scale, because those employer contracts will be behind those as well. Yeah.
So, thank you. So Zach spoke to at scale. I think not at scale. I think we can solve that problem ourselves in our own community by all of the specialists showing up here, networking with the people that they need, right? And then when you're here and you make yourself known to the folks that put together these plans, like some of the brokers here, then we'll take care of our own community there. And so, like I said earlier, we can make an influence in our area, and then if we're the model, then they can do that in other areas as well.
But I think maybe just the point I'll make there is when I say at scale, like scale always starts with a kernel, right, of something that's working. And so to me, that kernel of thing that's working is what you're talking about, right? Is that it's the DPCs working with the direct care specialists in a way that's kind of ad hoc. That to me is the kernel of scale. I don't think it's, you know, and then you figure out how do you scale that, right? As opposed to, you know, the direct specialty care, I think it can be successful standalone, but it won't go full mainstream unless it's deeply integrated with those referral pathways. And so that's the kind of long term, but it's the same thing. It's just kind of taken over a long time horizon.
Yeah, just to piggyback on that problem or question as far as second tier referrals, this is not an original idea, but you know, within the DPC ecosystem, you have certain population groups that are suffering from, you know, certain medical problems that need specialty care.
Yeah.
It can be stroke or, you know, whatever, very uncontrolled diabetes, maybe they need an endocrinologist. Is there a way to kind of compile this data and then the DPC docs use that to determine whether they should contract a specialist who is a direct care specialist for their population of patients?
Yeah, I mean, that type of idea, the short version is I think those types of things are what we need to do to take the sort of ad hoc thing and make it, you know, how do we make this? And when I say we, I don't necessarily, I'm not signing up necessarily to it, because my team I'll get in trouble with my team. But it's not necessarily off strategy with the type of thing that we would want to do, right? Because it would ultimately, you know, through the lens of kind of ensuring the success of our community, ultimately it does enable these DPCs to be more successful if they're able to more seamlessly connect with specialists. But, you know, yeah, anyway, maybe I'll pause there. I like the idea, I just think it needs to be executed and sort of taking that kernel of what's happening on a local level and sort of ensuring that's working. You can then, over time, figure out how do we, you know, systematize and scale that up. I don't know, I don't have all the answers, so, yeah. Yes.
All right, the scariest thing that you have to worry about is always what's in the shadows. So when you have your charts up there, it's got DPC, and it's got all these wonderful lines, and you talked about a 5-year potential time frame, but not 10. If we have more years, which there's nothing that says we will not have more years, or 12% at this point, is the change going to come quick enough to head off that horrible thing in the dark right now, which is socialized medicine? Every year we have it introduced. It was introduced again with more support than it's ever had before from Congress, with Bernie Sanders, 14 other senators, and 110 members of the House of Representatives all signing off as sponsors. With things going as they are, will we get to the point where people just throw up their hands and ask the government to fix something that we know how that's going to turn out, by the way? But will that happen, in your opinion? Because this is the thing that I am more afraid of than anything else, is that we won't have enough time to fix things before government intervention happens and we're in the socialized medicine state.
Yeah, so I would say, you know, there's a bit of a ring. Yeah. I would say I'll admit, I don't spend a lot of time thinking about regulatory stuff. You know, there's people on my team that do spend more time thinking about it, and we're very, very supportive of the various lobbying efforts and things that are happening as it relates to DPC. However, it's just, you know, kind of in my nature, it's like, what are the things I can control? And I don't sort of feel like I really can control that. And so I just sort of blind it out and just keep pushing. What I would say is that, you know, to the extent where I have thought about it, you know, stuff like that takes time, right? That's a big change, right? Like, maybe, but like, oh my God, that would be a big outcome. And what I would, if to the extent where we do end up there, I tend to think, okay, how do you sort of kind of create lemonade from lemon, right? Like if you do go in that direction, and I'd say I don't necessarily have very strong views on it, but I would want to say, okay, are the lessons we've learned from these thousands and thousands of doctors, can we protect can we protect them, right? Like, so that would be the view I would come from, is like, is there something that, if this change is going to happen, can we have it happen in such a way that doesn't destroy what's been built here? And I don't know what the answer to that is, and I'm not probably going to spend much time thinking about it, unless someone taps you on the shoulder and says, hey, this is kind of real. But that would be the role I'd want to play, is like, can we help shape this so it's not a disaster? And I'm sure there's others that have very strong perspective on that, but I'm just kind of a blinders on guy.
Okay. Last question before group picture and some more mingling.
Thank you for your talk. I don't really have a question. I have more of maybe an idea.
Okay.
That maybe a good approach to try and help tie in the direct primary care with the tertiary care and secondary care is to really do the research and get buy-in from the communities, because we're the ones that you're treating us, and we need to be able to voice our opinions without going through the normal channels.
When you say us, do you mean as a doctor view or a patient view? Patient view, yeah.
Because I do think that there's a lot of people who don't have options, and they, my husband, for one, is on Medicare now, so he's tied to that system. He doesn't necessarily get great care, and I have my health plan paid for by my employer, but I'm still willing to pay the $75, $125 for my DPC, rather than use what is given to me for free and include it in my employment package, my compensation package. So why can't we start bringing in the opinions and the success stories of the patients and work that into the model, so that we can gather that research and show the data on how effective the model is, and then you have something tangible that somebody can look at and say, this is great.
Yeah.
Because the success that I've personally had with DPC is wonderful.
Yeah, I mean, Dr. Roger, you've had some success with kind of bringing together data and sharing it with employers or patients. Do you want to share some of your stuff that you've done?
Thank you for that great question, and I hope you keep coming and connect with us and help us figure this out on a local level. And because it was amazing to me, like a year ago or so, we're looking back and looking at our growth and what's responsible for most of our growth. And it was mostly by word of mouth. And so it's how do we do more of that? That's why I wanted Dr. Salas and Dr. Musa to stand up and share a little bit of that, because people just don't know what they don't know. And so any way that we can come together and figure out how to share those success stories, let's do that. That's why I'm so thankful and blessed to have my co-founder have a marketing company. So Shankar and Atreya, they're just awesome at helping us get the word out, because that's really, I think what you're talking about. We need to be more visible. We need to share these wonderful success stories, and you would be amazed. Talk to any direct care doctor in here. We've got dozens and dozens of stories that are just so heartwarming, and it's just really the way medicine should be. It's been lost. We're all trying to restore it. So anything that anybody can think of to help us raise the awareness in the community, let's get together and do that.
Yeah, thank you for having me. Appreciate it.
All right, so our photographer has determined the best spot for the picture is there. Yes. All right, because of the lighting, so let's all move here.